Okay, so I'll start for today. So we were discussing hematology last week. Uh, we discussed about bleeding and coagulation disorders, right? Today I'll take a short lecture. I will discuss two important diseases, which are MRCP favorite topics. Basically, I will be discussing multiple myeloma and Waldenstrom's macroglobulinemia. So we know that there are some conditions where excess amount of proteins are formed, abnormal amounts of proteins are formed. They are called paraproteinemias, right? We all know multiple myeloma. We all know MGUS, monoclonal gammopathy of uncertain significance, Waldenstrom's macroglobulinemia. These are important topics for MRCP hematology, especially. Okay. So let's go through multiple myeloma first. You all know that it is a plasma cell neoplasm, right? It's a tumor of the plasma cells. It's usually you will have patients above 60-year-old. Male and female are equally affected, okay? So you'll have an elderly patient having certain symptoms, and just important to know that the abnormal antibodies that are formed in multiple myeloma are usually IgG mostly, and IgA and light chain disease. Okay. IgM is very uncommon to have an IgM multiple myeloma. Okay. When you have a high levels of IgM, that will lead your suspicion to another direction. So you have IgG, IgA, and light chain disease. These are the abnormal antibodies that are mostly produced in multiple myeloma. Very rare to have IgM. Okay. So you will have a scenario or with a raised IgG or IgA, or it will be mentioned that the light chain levels are high. So basically, you have an abnormal proliferation of plasma cells in the bone marrow, infiltrating the bone marrow, leading to pancytopenia. This cell proliferation causes osteolysis and hypercalcemia. So these patients usually present with features of anemia. They present with features of hypercalcemia. And of course, due to the huge load of antibodies in the blood becomes hyperviscous. Okay. So you have hyperviscosity syndrome. The blood becomes very viscous and blood flow to all the organs becomes very sluggish. So this is the basic pathology of the symptoms that are produced in multiple myeloma. And these are very favorite topics: the presence of anemia, hypercalcemia, and hyperviscosity, leading to a diagnosis of multiple myeloma. And of course, renal failure due to the tubular damage, due to the high load of antibodies in the renal tubules, damaging the renal tubules and leading to renal failure. So this combination of symptoms equals almost always equals to multiple myeloma. So this is a very common and very popular acronym for multiple myeloma features, CRAB. C for hypercalcemia, R for renal impairment, A for anemia, B for osteolytic and bone lesions. Okay, the typical bone lesions that we see in multiple myeloma. Okay, so this is a mnemonic to remember the symptoms of multiple myeloma. You will have features of hypercalcemia, features of renal failure, features of anemia, and you will have bone pain. So these are the features. As little bit details, you will have a scenario of an elderly patient having bone pain. Pains may even have pathological fractures. They have features of anemia, that is fatigue, malaise, features of hypercalcemia like confusion, polyuria, constipation, abdominal pain, repeated infections, features of renal failure. So you will have these features in an elderly patient. Not necessary to know all the details of the diagnostic criteria. Just remember that presence of more than 10% of plasma cells in the bone marrow, along with CRAB features. This was the typical diagnostic criteria used to diagnose multiple myeloma. The more easier diagnostic criteria would be this: presence of a monoclonal protein in the serum or urine, as we'll see later; presence of lytic lesions on a skeletal survey, and presence of more than 10% of plasma cells in the bone marrow. This is the basic diagnostic criteria that we use practically when we are managing patients, and this will be in your scenario too. Okay, so just if you need to know the levels, the calcium level is usually more than 2.75. The serum creatinine will be more than 177. There will be anemia. There will be one or more osteolytic lesions. Okay, these clues are usually given and help you to diagnose multiple myeloma. Sometimes they give you a globulin level or a total protein level also in your scenario. Okay, so when you see that the globulin level is very high or the serum total protein is very high, you suspect that this is a case of paraproteinemia. And of course, there will be a marked Rolo formation and a very high ESR. It's one of the conditions where the ESR goes more than 100. So your investigations, you will have anemia, you might have pancytopenia, you will have a very high ESR, you will have Rolo formation where all the RBCs are clumped together. The serum electrolytes, the serum creatine will be raised, the serum calcium will be raised. And as we will see later, beta-2 microglobulin, an important marker for prognosis, will also be raised. The serum total protein will be raised. Okay. And after that, the next investigation that you need, the next 3 investigations that you need are serum protein electrophoresis, that's very important to confirm the diagnosis of multiple myeloma. You need these 3 investigations. Number 1 is serum protein electrophoresis. Number 2 is a skeletal survey demonstrating lytic lesions. You can do, usually a skull X-ray used to be done, or you can do X-ray of the vertebra to look for any vertebral lytic lesions. But nowadays, CT scan MRIs are preferred because of the high sensitivity. An MRI spine is usually done. You might find a lytic lesion anywhere. But traditionally, an X-ray skull used to be done where the skull used to show lytic lesions. So in addition to protein electrophoresis, you do a skeletal survey, and very important, you need a bone marrow aspirate to determine the presence of the malignant plasma cells in the bone marrow to confirm your diagnosis. So these are the criteria for diagnosing multiple myeloma. You will be given a scenario where sufficient clues will be given to point a diagnosis of multiple myeloma. These are a few practical tips, usually not asked so much details in the examination, but sometimes serum protein electrophoresis might not be abnormal. You might not get any paraprotein in the serum. That's why you also might have to test the urine for presence of any paraproteins. So that's why it is advised to do 2 tests to determine the presence of a paraprotein, not to rely on a single test. Okay, so you do a serum electrophoresis and either a serum or urinary free light chain, because as I told you, the light chain antibodies might be present in a particular patient with no IgG or IgA. So a serum protein electrophoresis will not detect the light chains. So in addition to serum electrophoresis, we also do a serum or urinary free light chain assay. Okay, serum free light chain assay, that's called SFLC, serum free light chain assay. So that will help you not to miss a diagnosis of multiple myeloma. Serum electrophoresis along with serum or urinary free light chains. Okay, as you can see here, in 20% cases, free light chains are found in multiple myeloma cases without any detectable monoclonal protein in the blood. So this is very important. Okay.
Sir,
Yes, please.
Bernstein's protein is same as the free light chain?
No, that's different. Serum, here you can see in the urine, you might get free light chain, or you might get Bernstein's protein. The Bernstein's protein is the IgG and IgA secreted in the urine. That's different. So that's why you have to look for the light chain separately. Otherwise, you will miss the light chain multiple myeloma.